Hi, this is the second lecture in the basic science of orthopedics. In this lecture, we're going to speak about bone and cartilage histology and also about collagen. A good source that you can use is this book written by myself. Bone histology can be two types, can be trabecular, which is organized, or can be woven, which is disorganized bone, like the early cases of bone callus. The trabecular bone is two types, the cortical bone and the cancellous bone. We know the cortical bone, it is the bone that forms the bone cortex of the shaft bone, like shaft of the femur, shaft of the tibia. All these are cortical bone or lamellar bone. Cancellous bone is in the metaphysis of the long bone. This is considered cancellous bone. The cortical bone is different than the cancellous bone. It's dense. It means that less porous. There is less surface area for the same amount of the bone. It is stiffer and stronger, and it has slower metabolic rate. So the cancellous bone, on the contrary, will be more porous, will be more surface area, it will be less stiff, and it will be higher metabolic rate. So two types of trabecular bone, which is organized bone. It can be either cortical or cancellous. The cortical bone forms the cortex of the shaft of the bone. The cancellous bone, we can find it in the metaphysis. The cortical bone, as we said, is less porous, means it's more dense. It has less surface area. It is stiffer and stronger than the cancellous bone, and it has slower metabolic rate. These are all important points that comes into the questions. Now let's speak about the chemistry of the bone structure. So the extracellular matrix has about more than half, 60 to 70% mineral component, or what we call inorganic, and there is a 30% organic matrix, and the water content is relatively small, 5% only. When we go to the cartilage, we'll notice that the water content in the cartilage is much higher than bone. So again, inorganic or mineral is 60 to 70. Organic component, the matrix is about 30%. Water is a small 5 to 8%. The inorganic part is mainly calcium and phosphate, and as we said, it's more than half of the bone. It's about 60 to 70%, and most of this is calcium hydroxyapatite structure. Sometimes you're asked about what exactly the calcium hydroxyapatite. It's calcium 10, phosphate 6, and OH2. Calcium 10, phosphate group, which is PO4, 6, and OH, which is the hydroxy group 2. Calcium 10, phosphate 6, and OH2. One thing that can help you, that the number will go 4 with each time. So calcium 10, PO4, and then 10 minus 4 will be 6, and the OH 6 minus 4 will be 2. So most of the mineral inorganic material is calcium hydroxyapatite. Now the water content is, as we said, is small, is only 5 to 8%, and the organic matrix is about 30%, and most of that is collagen 1. So collagen 1, which is the most abundant collagen in bone, is about 90% of the organic, and if you put 90% of 30, it's about 20 to 25% of the bone. To sum up, the extracellular matrix, mineral or inorganic, is 60 to 70, more than half. Most of this is calcium hydroxyapatite structure, so it's calcium and phosphate, calcium 10, phosphate group 6, hydroxy group 2. The water is relatively very small, and then the organic matrix is 30%. Most of that is collagen type 1. When we go to the cartilage, we'll say that the cartilage is mainly collagen type 2. Now, after talking about the extracellular matrix, let's speak about the cells now. Bone cells, there are three main types of cell: osteoclast, osteoblast, and osteocytes. So these are the three bone cells that we are going to study now. The first cell that we're going to speak about is osteoclast. This picture is from my book. What is the function of the osteoclast? The osteoclasts actually work to resorb the bone. So they are the cells responsible for bone resorption, and they originate from hemopoietic lineage. So they are not from mesenchymal stem cells. When we go to the osteoblast, we'll say that it's coming from mesenchymal cells, but the osteoclast comes from hemopoietic cells from monocyte macrophage lineage. So they are hemopoietic cells from the monocyte macrophage lineage. They are not from mesenchymal stem cell. They have two distinct distinctive features: ruffle border, which is this, and the sealing zone, which this area here. So the sealing zone makes the osteoclast attached to an area of the bone and separate this part from the rest. That's why it's called sealing zone. And this ruffle border we're going to discuss more in the next slide. So to sum up, osteoclast, their function is to resorb bone. They are from hemopoietic lineage. They are not from mesenchymal cell. This is a simplified diagram of the osteoclast from my book. As you see here, it's a multinucleated giant cell. It has a ruffled border. It has something called the sealing zone, in which the osteoclast attached to a part of the bone and separate that from the rest. It happens through proteins called integrins and vitronectin receptors. This area here has a carbonic anhydrase system. The carbonic anhydrase system will push the hydrogen ion into this area, so this will lower the pH and will absorb the inorganic part of the bone. Also, there is enzyme like the cathepsin and metalloproteinases enzyme will absorb the organic part. So the carbonic anhydrase system push hydrogen, lower the pH, absorb the inorganic part. Cathepsin mainly, that's the main enzyme, and other enzymes like matrix metalloproteinase will absorb the organic part. So these together will absorb the bone, and you have an area here of bone resorption. So we spoke about the osteoclast function, which is bone resorption, and this bone resorption is the final pathway for all causes of bone resorption. The normal bone resorption has osteoclast. Remodeling that happens after fracture in kids has osteoclast as the responsible for that. Polyethylene wear, osteolysis, that's also osteoclast. Even metastasis and secondary hyperparathyroidism, this is depending on the final pathway, which is bone resorption through osteoclast. So commonly you will get a question say, what is the final pathway for wear related osteolysis? So it's not the polyethylene debris which is causing the osteolysis. The final pathway is by activation of osteoclast. And another tricky question is you will find a question asking in case of lung metastasis, for example, what is the causes of bone destruction that happen? It's not the cancer cell eating the bone. It is through activation of osteoclast. Another tricky question, what is the bone, what is the cell responsible for bone resorption in cases of multiple myeloma? It's not the plasma cell of multiple myeloma, it's through the activation of the osteoclast which will cause the bone resorption. A very important concept in the osteoclast, and we're going to discuss that in details in the next slide, is the RANK and RANKL. So the osteoclast precursor, as we said, osteoclasts come from hemopoietic lineage, will have something called RANK on it, which is abbreviation for receptor activator of nuclear factor kappa. And the osteoblast will have something called RANKL. Remember, the osteoblast has the RANKL, and the osteoclast precursor has the RANK. And the activation of an osteoclast precursor to osteoclast depend on that mechanism, which is the RANKL will activate the RANK and will causes more osteoclast to turn on and start bone resorption. So when osteoblast has more RANKL, that will result in more osteoclast activity. So remember, the RANKL is on the osteoblast. RANKL is on the osteoblast, and an increase in the RANKL will cause more osteoclast precursor to be changed in osteoclast, resulting in bone resorption. There is something called OPG, or osteoprotective. This is a competitor for the RANK, and it will come into contact with RANKL and block the RANKL. So it will OPG will decrease the conversion of osteoclast precursor to osteoclast. So again, the more RANKL available, the more activation of RANK, and the more osteoclast will change, osteoclast precursor will change to osteoclast. OPG will block the available RANKL and will decrease the activation of osteoclast, will decrease bone resorption. We're going to speak about that in the next slide again. and any factor that will increase the RANKL expression will result, as we said, into increase in osteoclast activity. So remember, the activation of osteoclast comes through the RANKL, which is on osteoblast. So the more RANKL you have, the more activation of an osteoclast precursor to osteoclast. So RANK is on the osteoclast precursor, RANKL is on osteoblast. The more RANKL you have, the more conversion that you have, the more bone resorption you have. OPG stops the RANKL or make less RANKL available, so it decreases the conversion and decreases the bone resorption, and we're going to put that into the next slide for confirmation. So this is the picture again. This picture is from my book. And I'm putting here into another slide because I'd like to confirm this concept is very important. It comes now in every exam. So the osteoclast, as we said, this comes from hemopoietic precursor. The osteoclast precursor changes into osteoclast through activation between the RANK and the RANKL. The RANKL is on the osteoblast. Osteoprotogreen or OPG block the RANKL, so it decreases this activation and it decreases bone resorption. There is a new medication, the denosumab is actually monoclonal antibody of the OPG, and it acts the same principle. So the denosumab will block the available RANKL, so the osteoblast precursor will not interact with the RANKL because there is less available for them, so there will be less osteoclast and less bone resorption. So what increases RANKL on the osteoblast? Some factors like interleukin-1, corticosteroids, continuous hyperparathyroid, all this will increase the RANKL, and that's how they increase bone resorption. So that mechanism is very important. It is the mechanism that explain increased bone resorption by many materials. These materials will act by increasing the RANKL on the osteoblast, as we said, steroids, continuous hyperparathyroid, interleukin-1, vitamin D, all this increases the RANKL here. And once you increase the RANKL, it will interact with the RANK and causes more osteoclast to go into osteoclast precursor to go into osteoclast, and this will result in bone resorption. Osteoprotogreen or OPG acts by blocking the available RANKL, and this will causes less osteoclast precursor to change into osteoclast and less bone resorption. Denosumab acts the same principle as OPG, so it decreases the available RANKL, it decreases the conversion of the osteoclast precursor to osteoclast, and it decreases bone resorption. After we spoke about osteoclast, let's speak about the osteoblast. In the osteoclast part, we said it comes from hemopoietic lineage. Osteoblast, on the other hand, comes from mesenchymal stem cell. This is a very important concept because, for example, in some cases of non-union or delayed union, there will be some material that has stem cells or some materials that enhance the differentiation of the stem cells into osteoblast. So osteoblast comes from stem cell. In general, stem cells generally I can differentiate into either fat cells, adipocyte, or cartilage cell, or it can differentiate into the osteoblast lineage. As we're going to see later, osteoblast is the source of osteocyte. So osteoclast comes from hemopoietic system, osteoblast comes from mesenchymal stem cell, and osteoblast is the source of osteocyte. Osteoblast lines the bone surface and they produce bone matrix. This is their main function, production of bone matrix. And one of the most important protein they produce is osteocalcin. I'd like to give a few points here about osteocalcin. Osteocalcin is a gamma carboxyglutamic acid protein. So if you remember in the blood cascade, we spoke about the carboxylation and we said it's a vitamin K dependent process. So osteocalcin is its synthesis also is vitamin K dependent. Osteocalcin is only produced by mature osteoblast. It's not produced by pre-osteoblast. So it can be used as a marker of differentiation of osteoblast because again it only comes from mature osteoblast. It has a role in bone mineralization and calcium hemostasis, and it can be used as a marker for bone density. As we all know, we mostly depend on DEXA scan to measure the bone density, but there are some blood work for bone density. One of them is osteocalcine. And osteocalcine is the most prevalent non-collagenous protein in mature bone. This sometimes comes as a question: what is the most prevalent non-collagenous protein in the mature bone? It is osteocalcine. So osteocalcine is the most prevalent non-collagenous protein in the mature bone. Other important aspects about osteoblast: it has the RANKL. I know I discussed this in details in 2 slides, but I'd like to repeat it. Remember, RANKL is on the osteoblast, and the more RANKL production and more RANKL expression on the osteoblast, the more cells that's going to differentiate into osteoclast, as we discussed. As we said, many pathways which end with bone destruction does this through more production of the RANKL on the osteoblast. So like tumors, multiple myeloma, polyethylene wear, all this will result in more production of RANKL, and more production on the RANKL on the osteoblast will result in more differentiation of osteoclast. Osteoblast also has the receptor for the parathyroid hormone, prostaglandins, steroids, vitamin D. So these all work through the receptors on osteoblast, not on osteoclast. As we discussed, we said osteoblast comes from stem cell. So there is a very important gene that is responsible for the differentiation of the mesenchymal stem cell into osteoblast, which is called core binding factor alpha 1, or CBFA1 or RUNX2, and this gene is responsible for differentiation of mesenchymal stem cell to bone to osteoblast. So of course, if there is a disturbance of this gene, a congenital condition can form. So if there is a loss of function mutation in the CBFA1, the condition that will result is cleidocranial dysplasia, in which there is a deficient differentiation of the bone, and as we're going to speak later, there will be absent clavicle in this case. So let's speak about the third cell, which is osteocyte. First, it was the osteoclast from hemopoietic lineage, then osteoblast from mesenchymal stem cell, and the third thing is osteocyte. Osteocyte actually comes from an osteoblast. The osteoblast, as we said, forms protein and produces the bone matrix, and it lines the bone surface. With time, the osteoblast becomes impeded into the bone matrix and becomes less metabolically active, and in this time it becomes osteocyte. So osteocyte are derived from osteoblast. They are much less metabolically active than osteoblast. They form much less protein, and they have a higher nucleus to cytoplasmic ratio. Osteocyte characteristically have processes that are connected to each other in the bone canaliculi, and through these connections there is a signal that happens in response to mechanical stimuli. And we know that this mechanical stimuli is the basis of the bone remodeling in the areas of maximum stress, as the wool flow. So the wool flow, as we're going to discuss later, it tells you about bone formation, and that bone formation is more in the areas that see more stress, and this happens through the connection between the osteocyte and the signals transmitted between the cell through the cell process, through the osteocyte process. So now we spoke about the 3 cells of the bone: osteoclast, osteoblast, and osteocyte. After speaking about bone cells, we're going to speak about the growth plate or the physis. The growth plate or the physis is responsible for longitudinal growth of the long bone. It is a cartilaginous part of the bone model. It's only present in the growing skeleton. So as soon as the child reaches skeletal maturity and the bone becomes skeletally mature, there is no growth plate. So presence of growth plate is what indicates that this skeleton is still growing. It gives the longitudinal growth of the long bone, and as soon as it matures, the bone becomes skeletally mature, and there is no longitudinal growth after that. The growth plate is divided into three main zones: resting zone, sometimes called reserve zone or germinal zone. The second zone is the proliferative zone. The third one is the hypertrophic zone. And in the hypertrophic zone, it is further subdivided into zone of the maturation, zone of degeneration, and zone of provisional calcification. However, some textbooks will consider zone of provisional calcification as a separate zone by itself. So this is why there may be some confusion with this topic, as some reference will indicate the zone of provisional calcification is a separate zone, and some will include the zone of provisional calcification as this one within the hypertrophy zone. So let's speak about these zones in more details. A resting zone or reserve zone or germinal zone, this has the cells that is responsible for later on formation of the phyces. It's a small round quiescent cell in a large amount of extracellular matrix. So if you see this picture comparing to the other, the matrix is large in comparison to the cell size. The proliferative zone, the cells start to proliferate. They form columns with the bone alignment, and they become flattened, as you can see in this picture. So the cell proliferate, forms column, and they become flattened. The hypertrophic zone, these cells start to become bigger. The zone of maturation, the cells will again become rounded, and then the zone of degeneration, which the internal organelles will start death. So the cell death and cell destruction starts in the zone of degeneration, and then the calcium will come outside of the cells to the extracellular matrix and give the zone of provisional calcification. As I said, some textbook will consider this a separate zone, and some textbook will consider part of the hypertrophic zone. So growth plate, the phyces only in the growing skeleton. It has a three main layer: reserve zone, and this is towards the epiphyseal area, and zone of proliferation, and zone and the hypertrophy zone. The hypertrophy zone is subdivided to zone of maturation, degeneration, and provisional calcification. The zone of provisional calcification is towards the metaphyseal area. The cells in the reserve zone are small in a large amount of extracellular matrix, and then they start proliferation and forming a flattened cell, and then they start becoming round in the zone of maturation. Then they start the degeneration and the zone of degeneration, and then the calcium will start into the extracellular matrix in the zone of provisional calcification. The reserve zone has the lowest oxygen concentration with low molecular activity. The cells in the reserve zone are quiescent, they are not proliferating, so they have a low oxygen concentration and low cellular activity. The proliferative zone is the highest rate of extracellular matrix synthesis. It is where the cells are forming and they are producing the largest amount of the extracellular matrix. The hypertrophy zone, it is where most of the physeal fractures will occur. So a zone of hypertrophy, especially zone of provisional calcification, is where most of the physeal injury will occur. Reserve zone, lowest oxygen concentration, low activity. Proliferative zone, highest rate of extracellular matrix synthesis, and then the hypertrophic zone, where most of the fractures will occur, especially in the zone of provisional calcification. There are two commonly asked aspects about the growth plate. One is how the mechanical support of the growth plate is provided. It's provided by precondylar ring of Lacroix. This is a ring at the outer aspect of the phyces and gives mechanical support. And as we said, the phyce is responsible for longitudinal growth. So an important question that you sometimes ask: how does appositional growth happen? Appositional growth is the growth at the periphery, and it's formed by groove of Ranvier. So remember, there's two things related to the phyces: the pericondylar ring of Lacroix that gives you mechanical support, and the groove of Ranvier is responsible for the appositional growth. Now, after we have talked about growth plate histology, let's speak about the pathology affecting the layers of the growth plate. Growth plate or the physis can be affected by many conditions, and most of these conditions affect a specific zone. So the reserve zone in which the cells are resting, and there is abundant extracellular matrix. The storage disease like Gaucher's disease affect this area. The proliferative zone this is the zone of proliferation of the cells. Overgrowth can cause gigantism, and undergrowth can cause achondroplasia. And the provisional calcification in which the calcium starts deposition into the extracellular matrix. This is where fractures or basically Salter-Harris injuries and slipped capital femoral epiphysis occur, and usually it goes, as I said, through the zone of provisional calcification, which is part of the hypertrophic zone, and the upper two zones, the reserve zones and the proliferative zones, remain intact. That's why in most cases after physeal injury the growth plate is not disturbed. Why? Because the resting zone and the hypertrophic zone are usually intact, and they can resume the activity of the growth plate later on. So that's why most of the growth plate the injuries, the Salter-Harris injuries, does not result in disturbance of the growth. The repetitive stress injuries like the little league elbow also affect the zone of provisional calcification, as it causes inhibition of the ossification in this zone, resulting in increased area that is radiolucent. So if you see this patient has a little league elbow, this picture is from first book, Pediatric Orthopedic for Primary Care Physician. If you compare, he's a right-handed young baseball player, so he's having little league shoulder here, which is repetitive stress, and it affects the zone of provisional calcification, so causing inhibition of calcium deposition. That's why the physis here looks larger than the physis here. So the repetitive stress, like the little league shoulder, causes inhibition of deposition of calcium in the zone of provisional calcification, which will result in apparent widening of the growth plate. Also, scurvy, which is less a deficiency of vitamin C, affect the areas of provisional calcification. To sum up, Gaucher disease and other storage disease affect the reserve zone. Proliferative zone is affected by overgrowth, gigantism, or undergrowth, achondroplasia. Provisional calcification, and remember, provisional calcification is part of the hypertrophic zone. So if you get a question and you don't see provisional calcification, pick hypertrophic zone. If you get like in which zone the fracture happened and you have both options, pick the provisional calcification. As I said, this area has some confusion because some textbook consider provisional calcification as a separate layer, and some of them considered it as part of the hypertrophic zone. Fractures and Salter-Harris injury occurs through the provisional calcification. Repetitive stress occurs through the provisional calcification, and scurvy occurs through the provisional calcification zone. So after talking about bone cells and growth plate, we're going to speak about very important protein in the formation of bone, which is collagen. Collagen also is important in formation of the cartilage, as we're going to see later. So what is the collagen? Collagen is a major protein in the bone, as we had discussed before. The collagen is a triple helical structure formed by alpha chain. Two of them are alpha 1 and one is alpha 2. And this alpha chain has the glycine every third amino acid. So it's glycine XY, glycine XY, glycine XY, and the glycine between different chains is connected covalently. The X and Y are frequently proline or hydroxyproline. So again, collagen, major protein in the bone and cartilage, as we're going to see. The collagen, as you can see here, is a triple helix. It means it's 3 chains forming a helix There is covalent crosslinks between the glycine. The glycine is every third amino acid. So it's glycine XY, and the X and Y are usually proline or hydroxyproline. Now let's talk about types of collagen. This is a very important concept that frequently comes in the exam. The most important point that I want you to remember is type 1 is the main collagen in the bone, type 2 main collagen of the cartilage. Remember this: 1 main collagen of the bone, type 2 main collagen of the cartilage. Type 1 is also present in the menisci and in the annulus fibrosus. This is the outer layer of the intervertebral disc. Type 2, as we said, main collagen of the cartilage, 90%, about 90% of the collagen content of the cartilage is type 2, and it is in healthy cartilage, the half-life is about 25 years. It's very stable. Other collagen in the cartilage is type 9 and type 11. Type 11 collagen is a thin fibril that will act as a deposition nuclei for deposition of type 2. Type 10, sometimes you're asked about type 10. This is plays role in the process of chondral ossification, and it is present in hypertrophic chondrocyte. So again, type 1 main collagen in bone, type 2 main collagen of the cartilage. Now, after talking about the histology of the bone, let's speak about the histology of the cartilage, which forms the articular cartilage. The articular cartilage consists of extracellular matrix and cells. The cells is only about 2%, so chondrocyte in the adult articular cartilage only represent about 2%. 98% of the articular cartilage is extracellular matrix, and the extracellular matrix in the cartilage is water is the largest constituent. If you remember, when we spoke about the histology of the bone, we said that water only forms about 5%. Here, the extracellular matrix, which is about 98% of the articular cartilage, water is the largest constituent, and then collagen, as we said, it's collagen type 2, and then proteoglycan, which are we going to discuss in the coming slides. So articular cartilage matrix about 98%, which is mainly water, followed by collagen type 2, followed by proteoglycan, and the cells is only about 2% in the adult articular cartilage, and this is the chondrocyte. Now let's talk about the layers of the articular cartilage. The articular cartilage has 4 layers: the superficial zone, the middle zone, the deep zone, and the calcified zone. This diagram is from my book, and it shows the 4 layers of the articular cartilage. This is the articular surface, so the joint side is on this side, and this is the bone side, so this is the subchondral bone. So first layer is the superficial zone. It is the only 10 to 15%, so it is the thinnest layer of the articular cartilage, and it is characterized by the collagen fibers are parallel to the articular surface. So here is the articular surface, and the collagen fibers are parallel. All the cells are elongated and along they lie along the axis of this layer. So the cells are elongated and they are with the parallel to the axis of the articular cartilage. This layer is characterized by it has the lowest concentration of proteoglycan, but it has the highest concentration of the collagen and water. So this layer, again, the superficial layer, this layer has the highest tensile strength because the motion is on the surface of the articular cartilage. So it has the highest tensile strength. It has the highest concentration of collagen and the highest concentration of water. However, it has less cells than the deep zone, and the cells are elongated and along the axis. So superficial zone, it's a thin layer. The collagen is parallel to the articular cartilage. The cells are less than the deep layer, and they are flat and elongated and parallel to the surface of the joint. It has a highest tensile strength, and it has the highest concentration of water and collagen and the lowest concentration of proteoglycan. If we go to the deep zone, it is thicker, it's about 30%. The collagen fibers here are perpendicular to the articular surface. So in the superficial it was parallel, in the deep it was perpendicular to the articular surface. And if you see the cells in this layer is more than the cells in the superficial zone, and the cells are aligned in columns that also are perpendicular to the joint. So cells are more, and they are lined in columns that are perpendicular to the articular cartilage. It has the highest concentration of proteoglycan. So this layer has the highest concentration of proteoglycan. However, it has the lowest concentration of water. Quickly, the superficial zone collagen is parallel to the surface. Here the collagen is perpendicular. The cells here are flat and less than the deep zone, and they are lined parallel to the joint. Here the cells are more than the superficial zone, and they are aligned in columns perpendicular to the surface. The superficial has the highest concentration of collagen and water, and this helps with the tensile strength. The deep zone has the highest concentration of proteoglycans. We have the middle zone, which is a big zone in between, transition zone between the superficial and the deep. And then there is the tide mark, which comes over the calcified zone. So the calcified zone is the fourth layer, and there is something called the tide mark. The tide mark separates between the deep zone and the calcified zone. The tide mark is seen only in the articular cartilage. So if there is like a cartilage over osteochondroma, you won't see the tide mark, and it is seen mainly in the mature articular surface. The tide mark separate between the deep zone and the calcified zone. So these are the layers of the articular surface. 4 layers. Between number 3 and number 4 lies the tide mark. When we talked about the cartilage extracellular matrix, we said that it has water, collagen, and glycosaminoglycan or proteoglycan. So in this slide, we're going to speak about glycosaminoglycan and proteoglycan and what is the difference between them, because there's lots of people who are confused between the difference of glycosaminoglycan and proteoglycan. We're going to illustrate this in this slide. So this picture here is from my book. So the glycosaminoglycans are actually linear polysaccharides. So examples like chondroitin sulfate and keratan sulfate, all these are linear polysaccharides, and these are the glycosaminoglycans. The proteoglycan, on the other hand, is a core protein covalently attached to glycosaminoglycan chains. So this will be considered a proteoglycan monomer here. It's a core protein attached to glycosaminoglycan chains like chondroitin sulfate and keratan sulfate. These proteoglycan monomers can become proteoglycan aggregates by attaching together through a backbone of hyaluronic acid and link protein. So the link protein will connect the proteoglycan monomer to the hyaluronic acid, and this will form the proteoglycan aggregates. So the glycosaminoglycans, these are linear chains of polysaccharide. The proteoglycan monomer is core protein attached to glycosaminoglycan chains. This is the proteoglycan monomer. The proteoglycan aggregates is multiple proteoglycan monomers attached to a hyaluronic acid through something called the link protein. So what is the function of the proteoglycan? The proteoglycan actually can be associated with up to 50% its weight of water, so it is responsible for the swelling pressure of the cartilage. So the proteoglycans give the swelling pressure of the cartilage through its ability to be associated with water. In the next two slides, we're going to speak about chondroprotective and chondro-ablative agents. So the chondroprotective, which are anabolics, includes tissue growth factor beta and bone morphogenic protein 2 and 7, and this works through intracellular signals, which is called SMAD3. Tissue growth factor beta, bone morphogenic protein 2 and 7, and also their intracellular signal, which is the SMAD3. Insulin-like growth factor, this also is a chondroprotective. It increases the collagen and proteoglycan synthesis. Glucosamine also has an anabolic effect through increasing the proteoglycan synthesis, and it also inhibits interleukin-1 induced decrease in proteoglycan synthesis. So basically it increases proteoglycan synthesis and inhibit the interleukin-1, which decrease its synthesis. So the chondroprotective, tissue growth factor beta, bone morphogenic protein 2 and 7, their intracellular signal SMAD3, insulin-like growth factor, and glucosamine. What about chondro-ablative or catabolic substance that has a negative effect on the cartilage? Interleukin-1 act by stimulating the metalloproteinase activity and cyclooxygenase. As we're going to discuss, these enzymes degrade the cartilage. It also inhibits proteoglycan synthesis. Same thing for tumor necrosis factor. It stimulates the metalloproteinase and it directly inhibits collagen synthesis. COX-2 enzyme and the metalloproteinase, as we said, these enzymes are catabolic and they cause direct degradation of the cartilage. And interleukin-1 and tumor necrosis factor, which stimulate the metalloproteinase, stimulate the cyclooxygenase and nitric oxide synthetase. All these work in the first few days after injury, and they are chondro-ablative. So we have enzymes here, metalloproteinase, we have the cyclooxygenase, and we have material like interleukin-1, which stimulate these enzymes and directly inhibit proteoglycan. Tumor necrosis factor, it stimulates metalloproteinase and inhibits collagen synthesis. And as we said, the enzymes themselves, COX-2 enzymes and the metalloproteinase. Remember, interleukin-1 and tumor necrosis factor are the main factor which acts in the first few days after injury. So what are the difference in the changes in the cartilage that happens with age and osteoarthritis? This topic frequently comes in the exam, so I'd like to present it in a way that makes easier for you. The most important difference in the changes with cartilage with age and osteoarthritis lies in the water content and stiffness. In aging, the water content decrease. So with aging, the water content decrease, and when the water content decrease, the cartilage will become stiffer, or in another word, higher modulus of elasticity, or in another word, less soft. So with aging, the water content decrease, and when the water content decrease, it becomes a stiffer cartilage, higher modulus of elasticity, or less soft. The reverse happens with osteoarthritis. The water content increase, and this will result in softer cartilage, or less stiff cartilage, or lower modulus of elasticity. The collagen it does not really change with aging process. However, it decreases in late osteoarthritis. The proteoglycan content decreases in both age and osteoarthritis. However, the mechanism of this is different. So the proteoglycan synthesis and degradation increases in osteoarthritis and decrease in aging process. So the content will decrease in both. However, the synthesis and degradation of proteoglycan increase in osteoarthritis and decrease in age. The main chondroitin sulfate, which is the chondroitin 4-sulfate, it decreases with aging and it increases with osteoarthritis. So the chondroitin sulfate decrease with aging and increase with osteoarthritis. The keratan sulfate increases actually with aging and decreases with osteoarthritis. So the chondroitin sulfate
decreases with aging and increases with osteoarthritis. The keratan sulfate increases with ages and decreases with osteoarthritis. The chondrocyte number decreases with aging. However, in osteoarthritis it increases. Both the proteoglycan synthesis and degradation and the chondrocyte in cases of osteoarthritis increases. So to summarize, the water content and the stiffness, this is very important difference between aging and osteoarthritis. The water content will decrease with aging, resulting in stiffer cartilage. The osteoarthritis will have increased water content, which will be less stiff cartilage. The proteoglycan synthesis and degradation, it decreases with aging and it increases with osteoarthritis. Chondrocyte number decreases with aging and increases with osteoarthritis. The keratan sulfate increases with aging and it decreases with osteoarthritis. The chondroitin sulfate, it decreases with aging and it increases with osteoarthritis. So just remember the water content and stiffness, because this is the most frequently asked question. So water content decreases with aging, resulting in stiffer cartilage. The water content in osteoarthritis will increase, resulting in less stiff cartilage. The synovial joint, I'd like to explain some of the points that sometimes come in the exam. The synovium is composed of two layers, intimal layer and the connective tissue sublining. The synovium does not have a basement membrane. There are two types of cell. Type A, this is our macrophage-like cells, so they are responsible for phagocytosis. Type B, they are responsible for the synovial fluid production. The synovial fluid has hyaluronic acid, has lubricin, proteinases and collagenases. It's secreted, as we said, by type B cells. These are the ones responsible for the synovial. And the synovial fluid exhibits non-Newtonian flow characteristics. It means that the viscosity coefficient is not constant. It's not the same viscosity coefficient. Viscosity increase as the shear rate increase. Let's speak about lubrication in the synovial joints and in the articular cartilage. The main mode of dynamic lubrication of the articular cartilage is the elastohydrodynamic lubrication. In this type, there is deformation of the articular surface and a thin film of joint lubricant separating the surface. So elastohydrodynamic lubrication, the main mode of dynamic lubrication of the articular cartilage, there is deformation of the articular surfaces and a thin film of joint lubricant. The boundary lubrication, this occurs with non-deformed surface. In this case, the fluid film is depleted between the articular surfaces, and the bearing surface will be only separated by boundary lubricant. The hyaluronic acid diffuses from the cartilage and binds to lubricin, and we're going to discuss lubricin in the next slide. So lubricin and superficial zone protein, as we mentioned quickly in the previous slide, they both share similar primary structures. Both lubricin and superficial zone protein, they have a very similar structure. They are glycoprotein and they are produced by the chondrocyte in the superficial zone. Both are responsible for the boundary lubrication. As we discussed in the previous slide, the boundary lubrication occurs with non-deformed surface in which the joint and the bearing surface are only separated by boundary lubricant, and this will help to decrease the friction between the surfaces of the joint. As we discussed in the previous slide, hyaluronic acid with compression, it will diffuses from the cartilage and it will bind to lubricin, creating the cross-link protein and the boundary lubricant. So the boundary lubrication, as we discussed in the previous slide, has the lubricin and superficial zone protein as an important element of it. The hyaluronic acid will diffuses from the cartilage and bind to lubricin, creating a cross-linked protein, and this will act as the boundary layer. Thanks for listening to this lecture. If you'd like to connect to me with any question, you can email me on orthopedicsurgeon@amrabdelgawad.com.